Cryptogenic organizing pneumonia. Previously known as bronchiolitis obliterans organizing pneumonia. Etiology. Not known. Possibly results from viral infection, cryptic antigens, or capsid proteins. Cryptogenic organizing pneumonia, COP, may be a manifestation of, or be associated with, various medical conditions. This is predominantly connective tissue disease, but other reported conditions include infection, viral, mycoplasma pneumoniae and HIV, vasculitis, drug toxicity, toxic fume inhalation or smoke inhalation, post-radiation, aspiration and transplantation. Pathology. Bronchiolar and alveolar fibrous plugging. Lung architecture is preserved, no fibrosis. Epidemiology. COP occurs most commonly in the 5th and 6th decades of life, and has no gender preference. Clinical presentation. Typically there is a subacute, 6-10 weeks, onset with flu-like illness, fever, malaise, and weight loss, persistent cough and breathlessness. Occasionally there is a fulminant presentation with rapidly progressive severe disease. Physical signs. Inspiratory crackles are heard in up to 74% of cases, but physical examination may be normal. Investigations. Blood tests, neutrophilic leukocytosis in 50% of patients and elevated inflammatory markers, erythrocyte sedimentation rate and C-reactive protein. CXR, patchy, bilateral, and variable-sized areas of consolidation predominantly in the lower lobes, often peripherally. The infiltrates may be migratory. Unilateral changes occur in 5% of cases. High-resolution CT scan, bilateral, patchy, and asymmetric areas of airspace consolidation with ground glass opacities. These are mainly in the lower zones with a subpleural or peribronchial distribution. Pulmonary function tests, restrictive defect with reduced DLCO. Arterial blood gases, resting or exercise hypoxemia in 80% of patients. Video-assisted thoracoscopic lung biopsy, this is the most helpful examination. A wedge biopsy is required to avoid sampling and interpretation errors related to patchy interstitial changes. As COP often requires lengthy corticosteroid treatment, histopathological confirmation is strongly recommended, if clinically feasible. Differential diagnosis. A variety of other disorders may have a similar presentation, such as infections, including opportunistic, pulmonary lymphoma, beware, as this may initially improve with corticosteroids, usual interstitial pneumonia, bronchoalveolar carcinoma, chronic eosinophilic pneumonia and sarcoidosis. Treatment. Oral corticosteroids are usually very effective. The optimal regimen is uncertain, but usually high-dose prednisolone, 1.0–1.5 mg/kg daily, is recommended, gradually tapering to 0 over several months. Most patients improve within several weeks to 3 months. Prognosis. Excellent in the majority of patients. However, relapses are common, 58%, especially within the first 12 months, so close monitoring with CXR and pulmonary function test is recommended. Patients with frequent recurrences, more than 3 episodes, may require low-dose maintenance corticosteroid therapy. NB. Although COP is uncommon, it should be included in the differential diagnosis in any patient with bilateral airspace radiological changes that are unresponsive to antibiotics.